Is there a problem, Nihal?
Yeah, because there was somebody who said they're not able to hear. No sound. Dr. Pinky, can you hear us? Please reply. Yes, we are good. I think we can start now.
Good evening. I'm Dr. Kesha Jani from IAP Digital Media team. I'll be your host for today's webinar on conservative management of glenohumeral joint arthritis with resource person Frederick Schroer. The moderator for our today's webinar is Dr. Nehal Shah. This is the first webinar in the international webinar series being organized by the Indian Association of Physiotherapists. IAP is the oldest and largest association representing physiotherapists in India since 1955. The association's digital media team consists of a group of physios who handle Zoom platform, webinar live streaming, and IAP profiles on social media platforms such as Facebook, Instagram, Twitter, LinkedIn, YouTube. Follow IAP profiles on these social media to receive notifications for our events such as webinars, workshops, CMEs, conferences, health camps, blood donation drive, and to know the recent updates on physiotherapy. You can even subscribe to IAP YouTube channel for notifications of our live webinars. In playlist section of this YouTube channel, webinars are segregated into various folders on topics like orthopedics, neurology, sports and fitness, pediatrics, cardiopulmonary, women's health, research, cancer rehab, etc. The social media links will be shared in the chat shortly. Now, I'll hand over to our moderator, Dr. Nehal Shah. Thank you, ma'am.
Thank you very much, Kesha. Good evening, one and all present. I, on behalf of the Indian Association of Physiotherapists, on behalf of our President, Dr. Sanjeev K. Jha, sir, Vice President, Dr. Suresh Babu Reddy, sir, our General Secretary, Dr. K. M. Annamalai, sir, our National Treasurer, Dr. Ruchi Varshney, ma'am, and entire CEC of IAP. Welcome, Dr. Frederick Schroer, for our first webinar. This is a part of celebration of World Physiotherapy Day with the theme of arthritis and some other form of inflammatory arthritis. It is indeed an honor for me to introduce our resource person for today, Dr. Frederick Schroer, who is from France. He's a French physiotherapist with more than 20 years of teaching and clinical experience. He is a shoulder specialist. He is a co-founder of the French Society of Rehabilitation and a member of European Shoulder and Elbow Rehabilitation Society. He is also a national counselor of the French Order of Physiotherapists. He has wrote many scientific papers. He has also contributed in many books pertaining to musculoskeletal diseases and evidence-based practice. It is indeed an honor for us, sir, to have you here and to listen from you regarding the recent aspects of conservative management of glenohumeral arthritis. And without wasting much of time, I'm handing over to our resource person. It is all yours, sir, now.
Okay, thank you very much, Nihal, for the presentation, and thank you for the invitation. It's an honor for me to talk with my colleagues in India. It's such a great thing to speak with the Zoom and speak with the webinar. It's a very good technology. Like this, we can have communication all around the world, and we can participate to knowledge all around the world. We did a lot of webinar in France during the COVID period, and now it's like something we do very often in France. I think it's a very good way to learn. For the invitation, Neil asked me to treat a point about the glenohumeral, about arthritis. As my specialty is the shoulder, I decided to speak about the glenohumeral joint arthritis, shoulder arthritis, and its conservative management. So I'm going to talk with you about this, and if you want to maybe ask some question, You can use the chat. I think, Nihal, it's possible. And I let you ask me the question of the participant.
Yeah, we'll just have a look at the chat box, and I'll keep on posting you with the questions as and when they come. Okay,
great, Nihal. So first of all, what is important to understand is that osteoarthritis, shoulder glenohumeral arthritis is the same disease than in the other joints. It's the same disease than in the other joints. It means that, excuse me, I just put that down like this. I can see everything. Okay. It means that it is a question of cartilage structure damage, and it is increased in mechanical stress. It is an increase in mechanical stress, but not only a mechanical stress. We know it now, it's an inflammatory disease. Subchondral bone changes with spurs, or I don't know if you say bone spurs or osteophytes in India. You know, it's the little kind of bones that are going through the joint after when there is arthritis, and also of bone on humeral head, and inflammation, of course, and structure modification on the joint, around the joint, not only the cartilage. It's a question of capsule and ligaments. So it's the same than on the knee. Glenohumeral joint arthritis is the same disease than the other joint. It means that it's just a disequilibrium between constriction and destruction. Chondrocytes function disturbed, and we know that in shoulder there are more shoulder arthritis in women, and a recent study in Asian people shows that 60% over 65 years old had shoulder arthritis, glenohumeral joint arthritis. It's low than knee arthritis, than hip arthritis. So it's more women like in the other joints, but it's less common than in the other joints. The risk factors are history of trauma or dislocation. History of trauma is the same than in knee, but dislocation is specific for the shoulder. All people who had dislocation when they are young, they have more risk to develop osteoarthritis of the glenohumeral joint. And even when they had surgery, I don't know if in India you do the surgery, Nihal, with the butyl-latarget. It means with the coracoid process we put in the front of the shoulder for people with dislocation. I don't know if you have that kind of surgery, but if you have that kind of surgery, which is a very good surgery for young people with dislocation and sports people, so all that people who had this surgery have more osteoarthritis, glenohumeral joint in the year after. And obesity is a risk factor too, sport injuries, of course, massive cuff tear. I will speak about this later. Smoking, and all kind of dysplasia of the glenoid and of the humeral head, and genetic factors too. You see, so it's not just a question of stress, mechanic stress. It's all that factors that comes in the arthritis, in the glenohumeral joint arthritis. Glenohumeral joint, it's not exactly the same than the other joint. It's not mechanically the same. You know, when you see the hip and the knee, they are joint on the floor with a charge, with the weight of the person on it. The shoulder is not the same. It's not working like in the picture. Shoulder is working in kinetic, open kinetic chain, when a lower limb are working a lot on closed kinetic chain. But if we are looking to mechanical studies, we can see in a lot of mechanical studies with shoulder models, that the compressive forces of the rotator cuff and the moment arm of the upper extremity lead to substantial glenohumeral joint reaction forces, which is close to 50%, up to 1% of body weight at 90 degrees of abduction. You know, just when we put our arms in that position, 90 degrees of abduction, there is like full body force on the glenoid. So that's a lot. And it's even more if you are lifting weight. So if you're a worker, or if you practice gym, you will have a lot of compression in the shoulder, even if the shoulder is working an open kinetic chain. So there are different types of glenohumeral arthritis. Walsh is a French surgeon. He did a classification of the different type of arthritis. It was more than 20 years ago. The first classification is the type A. It's the most common, and it's around 60% of the person with glenohumeral joint arthritis. In that situation, the head of the humerus is centered on the glenoid. The type B, you see there is a subluxation, posterior subluxation of the head of the glenohumeral joint. That is very important for us in physiotherapy. Why? Because we are used to do mobilization with our patients in manual therapy. And we do like to do posterior glides. When we have stiff shoulders, like in frozen shoulder, we do a lot of posterior glides. And that will be completely prohibited in front of arthritis. And as we don't always know if the humeral head is behind, is posterior, or if it's centered, because it needs to have X-ray. So we will be very, we won't do posterior glides because it could increase the pain of the patients and maybe the inflammation of the joint. The last situation is the C type, and that's for the dysplasia of the glenoid. It's more rare. There are two types of glenohumeral arthritis that is very important for physiotherapists to do the difference. Primary glenohumeral arthritis, it means it comes because of genetic factors, and there is nothing else. There is no trauma, no sports injuries, not things like that. And people have arthritis. This primary glenohumeral arthritis is center. You see, there is here no more joint, no more cartilage. Here we see, do you see when I move here in my computer, when I show the humeral head?
Yes, sir,
Okay.
we can see it.
We can see that.
Great. Okay, great. This is the spurs, bone spurs. You see, the head is not like a normal humeral head. And here there is no more joint. Here there is a lot of density of the bone. And here there is less density of the bone. If you look at normal shoulder, you see the difference of the joint here and the humeral head form. But there is something important, is that line, that is the line of the lateral border of the scapula, is in continuity with the medial border of the humerus. You see, it's like that. This is a primary glenohumeral arthritis center head. The problem of that kind of arthritis is the stiffness, because when the joint is going to disappear, people and patients won't move the arm anymore, and they will have a lot of decreased mobility in the shoulder, especially in lateral rotation and elevation and abduction, all mobilities. The second type is a secondary glenohumeral arthritis to a massive rotator tear. Look at the difference on the X-ray picture. This situation, the humeral head is not centered. It is not centered on the glenoid. Why is it like this? Because there is no more rotator cuff in this shoulder. So actually the head is going up because there is no more rotator cuff, and it's going closer and closer to the acromion here. You know, it's like a new joint here. The problem of that kind of shoulder is not the stiffness. The problem is the strain, because there is no more muscle, no more rotator cuff. But for both people, primary And secondary, with rotator cuff and with no rotator cuff, the problem is the pain, because people are going to visit a doctor because of the pain. So I wanted to show you what kind of surgery we surgeons do. In the primary, when there is the older rotator cuff, when the surgeon is going to replace the shoulder, he has to do a tenotomy of the subscapularis, and that is very important. He's going to change the head and the socket, and after that, he will do a suture of the subscapularis. That's very important. Why? Because when we will receive the patient for the rehabilitation, it will be completely prohibited to do lateral external rotation of the shoulder, because it's dangerous for the suture. During 6 or 8 weeks, we won't do that kind of rotation, lateral rotation, to preserve the suture. The other surgery is for people without rotator cuff. So in that case, the surgeon cannot put an anatomic arthroplasty, because the people won't elevate the arm even with the arthroplasty. So there is a reverse shoulder arthroplasty that put a ball on the socket and a glenoid in the humeral head. And after that surgery, people will elevate the arm with the deltoid. Usually, there is no suture of the rotator cuff because there is no more rotator cuff. But actually in France, a lot of surgeons are using that kind of arthroplasty, even if there is enough rotator cuff, so they do tenotomy. So you have to see the notice of the surgeon of what he did on the shoulder to know if there is a suture or not, because for the rehabilitation, it's very important. But what is important for us, because I was speaking about conservative management, so I have to tell you what we do in case of arthritis in conservative management. Look at that pictures. It's very evaluate arthritis where the joint completely disappear, a lot of spurs, a lot of calcification. This patient is 74, 75 years old. Look at the patient. She can elevate at 150 degrees. Of course, the movement is not in the glenohumeral joint. All the movement is, look, even in her low back. Look at the lumbar spine. She's elevated with the spine and with the scapula. Look at her face. She's smiling. She can put her hands behind the head. She can even put the hand behind her. So that's patient. Yes, she's stiff, but she doesn't have pain. And if there is no pain, and if there is enough function, there won't be any surgery. The surgery is for the pain, and the surgery is for the disability. If a woman like this at 75 years old, she's like that, and she's okay with that problem, she has not a lot of pain, it's not a good idea to do the surgery, but she can do rehabilitation. So, what can we do in rehabilitation? First of all, we're going to evaluate our patient. Evaluate the risk factor. We spoke about this just before. We're going to evaluate the pain with a scale and what kind of medication the patient takes. Does he or she takes analgesics or non-steroidal anti-inflammatory? It's important for us to know that. And it's important to ask the patient how the patient sleeps, because if he doesn't sleep well, he won't have any recovery. That's very important. Did he have any injections? Injections of what? Of steroid intra-articular? We do it in France, steroid. We do 2 hyaluronate injections. It's not as efficient as on the knee, but it can help a little bit patients for the pain, or maybe to do the surgery a little bit later. Other injection exist, PRP, platelet, or growth factors, but we don't have a lot of evidences about that kind of injections. We're going to evaluate the active mobility of the patient, like we saw with the woman just before. And we're going to evaluate the participation of the scapulothoracic mobility and the thoracic spine. Look at this mobility in the patient, look at this picture in a patient of 84 years old, okay? The big spurs and no more joints here. It's completely no more joint, no movement. Look, when you look at him, he's very kyphotic. He has a kyphosis of the spine. But when you ask him to elevate the arms, look how we do that. Look the elevation. He can do a good elevation, and the hands are in the same position on the top. Why? Because he's using his thoracic spine. Look here, all the thoracic, all the scapula maybe is moving well, and that with that possibility, he can elevate the arm like this. Even in abduction, you see the right shoulder? It's not moving a lot. There is not a lot of mobility in the glenohumeral joint, but he has the possibility for the compensation in the other kind of, in the thoracic spine and the scapulothoracic. That situation is very important for us. It means that if the patient doesn't have pain, maybe he can have less disability than in the knee. If you have 20 degrees less on a knee, you will have a lot of disability in your life. If you have 40 degrees less in glenohumeral joint, you will be able to elevate the arm with the other joints. Look this picture. It's less arthritis because it's a young man of 46 years old. 46 years old is very young to have arthritis, shoulder arthritis. He already have a big spurs here, and the joint is quite completely dead. Look how he's elevating his arm. It's the left one. You see, it's difficult for him to elevate. Maybe more difficult than the patient just before, and his arthritis is less evaluated than the patient just before. Look his arm, look the left shoulder here. It's very difficult for him. We see like fibrillation, muscular fibrillation, because it's hard for him to elevate. And look, he's quite in the same position of the hand, but he has really more disability than the other patient. Why? Because he's young and he wants to practice sports, and he cannot do all the sports he wants with that kind of disability. 46 years old is too young to have an arthroplasty. So we need to help him with a conservative management, to help him to get maybe more mobility on the glenohumeral joint, on the other joints, and we're going to see how to do that. We're going to evaluate the passive mobility, of course. You see, we do that on the standing position and on the dorsal position. Look at the arm. When I put the arm on elevation, my elbow is getting up. Look the position of the elbow, because the patient cannot do a real abduction. Like in the other arm, if I do the abduction elevation, she can do that, and the arm is close to the ear. In the other arm, because she doesn't have the same lateral rotation, when I do the elevation, look, the arm is close to the mouth after. So we can look that kind of passive mobility decrease, and we have to evaluate all the mobilities, all the range of motions in abductions, in flexions, lateral rotation, and internal rotation on the back. It's very important to see that. Evaluation, we have to evaluate the psychological factors like depression, because the depression is maybe because of the pain, but maybe the old patient has a depression. And we know that someone who has a depression shouldn't go to the surgery, because we do know that even 2 years after, the results will be less good than if the patient has no depression. So we have to talk with the patient and ask them how they feel in their life. Do they sleep well? Do they have problems? Are they alone in the house, or do they have family around them? Because if the patient is living alone, will he or she be able to be independent after a surgery with the arm completely in immobilization? So that kind of factors are important for the rehabilitation and even for the surgery. And we have to evaluate to the comorbidities with cardiovascular disease and even diabetes or obesity, because we do know that that kind of comorbidities give less good results of our rehabilitation and surgery. Rehabilitation of the glenohumeral arthritis will concern patients for conservative treatment, but even as a pre-surgical treatment to improve the postoperative results. We can see the patient in both situations. The rehabilitation will be exactly the same. Just for patients who will go to the surgery, we will try to increase mobilities, and for conservative treatment too. For both treatment, we do not have good guidelines to help us to do the rehabilitation. Surgeons have good guidelines. We don't have good guidelines for osteoarthritis conservative treatment. We do have for post-surgical treatment. First of all, if you're looking for physical agent, I don't know if in India you are using like cold pack, hot pack, or electrotherapy or laser therapy. We don't have any papers for that. What we know is that for all that kind of physical agents, there is a lack of evidence for other kinds of shoulder pains, like in rotator cuff tendinopathy or frozen shoulder. There is a lack of evidence that it is good treatment. So you can do it if you want, maybe based on your clinical experience or on the patient's preferences. But the most important, you already know that it is not a treatment. It is just an adjuvant. It's just a part of the treatment. If it can help you to do the mobilization, to do the exercises, it's okay. But you cannot do all a set of rehabilitation with that kind of physical agents. We can do like stretch muscles or muscles energy technique, pain inhibition. What we are doing is not on the joint. I think it's dangerous to move and to do glides on the humeral head with an arthritis, because we don't know what is there exactly and how is the head. Is it posterior? Is there a posterior subluxation like in type B or not? So an advice I could give you is not to move too much the glenohumeral joint like we do that in the frozen shoulder. So maybe we stay in the suburb of the glenohumeral joint, just in peripheric, and we're going to treat the muscles. In this video, you can see that the physiotherapist is just treating the teres major here. He's going to stretch the teres major here, because it's a muscle, very short muscle and tough muscle, that when he has contracture, he will decrease the range of motion of the shoulder. Physiotherapist is very close to the arm of the patient. Look how it takes the arm very close. This hand on the top, proximal hand, is close to the joint. The other hand is close to the scapula, and the body of the physiotherapist is close to the arm. Like this, the patient has more assurance. He is less scared to have pain. That position, it is if the patient has low mobility. If he has more mobility, you can do that kind of technique with more lateral rotation, and always doing here a stretch on the teres major. You can do an energy technique like this. You will ask to the patient to do a contraction, muscle contraction, and he release, and afterwards we do the stretching. Other kind of things important is the strengthening of the shoulder. I think it's very important for our patient to do exercise with resistance. Of course, we won't do hard resistance with our patient. They are old, but I think we have to do that. We have to do that because it's not dangerous, and we are using soft resistance for the patient, and we are hearing their pain if it's okay for them. Why do I do resistance technique for a stiff shoulder, especially for stiff shoulder, but even for secondary arthritis? There was a paper of Rawat, who is Rawat is an Indian physiotherapist, and he published in 2017 a paper to say about the strengthening in frozen shoulder. Rawat is wait a minute, is for, I don't know if you know him. Strengthening. Okay, Rawat is from, he published that in Journal of Hand Therapy, and he's from Mangalore, Karnataka in India. I don't know if he's working in a hospital. He did a trials about the interest of the doing strengthening exercises for frozen shoulder, and good results for patients. So now every time, now we have, it was in 2017, and we have other papers now. It was the first one. And now in all my patients with a stiff shoulder, frozen, or glenohumeral joint, I do strengthening. And I think it's very important for our patients because they need to contract their muscles for conservative treatment, but even in preoperative treatment for the post-surgical rehabilitation. We do rehabilitation on the scapulothoracic. We can do mobilization of the scapulothoracic because it will help the patient to elevate and move the arm. If the glenohumeral thoracic can help, because it will help on the mobility of the acromioclavicular joint, which is a place a lot of arthritis too. But you can move that kind of joint better than glenohumeral joint when you have arthritis on that place. So you can do that kind of mobilization. Here we do posterior tilt here, and if you do posterior tilt of the scapula, it will help your patient. Excuse me, I will do on the beginning. Here you see I'm doing a posterior tilt with my proximal hand. It will help to elevate the arm, and I will do after an anterior tilt. Here you see how I do the anterior tilt, and the anterior tilt, it will help to go on the back. I do like adduction of the scapula and protraction of the scapula, and all that mobilities of the scapula will mobilize the clavicle joint, and it will help the patient to get better mobility in the arm, because the goal of the rehabilitation is not to have more mobility in the glenohumeral joint. It is to help people to use better the hand to catch something on the top. And for that, we are looking for mobility everywhere. You can help people with scapulothoracic joint with the muscles too. And look, this person who is 75 years old, maybe she's doing exercise with the scapula, and she's doing with weights. 1 kilo weight, it's not a problem. You can ask your patient to do exercises with 500 grams, 100 kilo, and do the mobility like this with the shoulder. It will help a lot them. And it will help to do the mobility of the spine mobility in a global function. Look here, I'm asking the patient to put the balloon on the top, And I don't ask her to do a perfect movement with the shoulder. I don't care about this. I just want her to have the hand going up, you see? And maybe completely up like this, look at the right shoulder. It's completely elevated. She's doing a shrug like this. It's not a good movement. I will correct another patient who has maybe a tendinopathy on that movement. But her, I don't correct her. I ask her just put the balloon maximum on the top and elevate maximum the balloon. Like this, she will contract a lot her deltoids, her spine, her muscle spine, and muscle scapula too. Don't forget to do global exercise for your patient. They are old, and to do aerobic exercise. I think there is a place for that. We do know there is evidence that the aerobic exercise are good for the pain and for psychology too. So tell to your patients to walk, and tell to your patients maybe in the office when you are working with them, you can ask them to do like bicycle in the rehabilitation place, and to do that kind of very global exercise with the arm, with the spine, with the shoulder, with the lower limb. It's not because a patient is coming just for a shoulder arthritis that you don't have to care all the body of the patient. I think it's very important, and we do know that it will help our patient. So the take-home message is well, Glenohumeral arthritis is less common than other joints arthritis. As an articular complex with 4 joints, shoulder can use scapulothoracic joint, clavicular joints, and even thoracic spine to compensate the deficits of the glenohumeral joint. So that's the point important for physiotherapists. Use the other joints to get more mobility of the arm. Sometimes patients need a surgery, but if there is no pain and enough function, it's not necessary. It is not necessary because we are looking for patient abilities, not X-ray. We don't have good guidelines for the rehabilitation, so we have to be pragmatic. Patient is in front of you. What does the patient need? He needs more strength because he has no more muscle. Okay, I will help him to get more muscles. He is completely stiff. I'm looking for mobility in the other joints. Our rehabilitation is few specific on the glenohumeral joint, but a lot global with all joints and muscles around the shoulder. It's very specific for the arthritis. We don't do that for frozen shoulder, for example. And respect patient's pain. We do know that for tendinopathy, we can play with the pain of the patient. It means sometimes patients have a little bit pain, but we can accept this, and we do know that it will be better for the rehabilitation of the tendinopathy. But for the arthritis, no pain, not during the rehabilitation, and not after, of course. Thank you for your attention. If you have questions, I'm hearing you.
Thank you so much for this session. Before the before the crowd asks you, I want to sort out certain queries. Can I?
Yes, of course.
Yeah.
You want me to stop the? Okay.
Yeah,
like
that should be great. Yeah.
Okay, great.
So my question to you was that we have been talking about this shoulder rehabilitation, shoulder arthritis, and I just wanted to know the role of a physiotherapist for a scapular dyskinesis, because that is very common with the shoulder problems. So what approach should we as physiotherapists take to treat this scapular dyskinesis?
I think,
Yeah, because we have been reading a lot about middle trapezius strengthening, lower trapezius strengthening, serratus anterior strengthening. So, with your experience, we would like to know more about it.
Okay, so thank you for the question. It's important. When you are looking to a dyskinesis, you have to know why there is this dyskinesis. And there are two possibilities in the arthritis I told you. First of all, the stiffness of the shoulder. If you have a stiffness of the shoulder, the dyskinesis of the scapula is exactly the same than the frozen shoulder. Exactly the same. It means there is too much elevation like this. The difference is frozen shoulder is going to be okay at the end. A frozen shoulder will be treated completely, and the patient will recover all the mobilities, and the scapula will move normally. And patient with arthritis, the patient will elevate the arm like this all the time. You cannot prohibit that. It will help him to elevate the hand. Not forget the goal of the rehabilitation of patient with arthritis. The goal is to use the hand, not to have a good movement in the scapula. And if the patient is coming 90 degrees with the hand, and maybe after he has 110 degrees with an elevation of the shoulder, it doesn't matter in arthritis. It's very special. The second situation is with patients without any more rotator cuff. They have arthritis and there is no more rotator cuff. So the patient are elevating the same, exactly the same, but the big difference is that they have passive mobility. They have passive mobility like this, and it's the same. Why do they have dyskinesia? They do have this dyskinesia because there is no more force in the shoulder. So we do have to help them to get more force, and sometime the dyskinesia is disappearing because the patient has more force in the shoulder. So I think in that kind of patient, old patient, because they are old in that kind of disease, the problem of dyskinesia is not the same than in thrower athletes, you know, in thrower athletes who were doing baseball or tennis. We are looking a lot about the dyskinesia. It's very important because sometimes it means that the shoulder is going to have a problem after. But in that kind of problem, it's not the same.
And out of the context of this, we have also seen that patients who are coming with neck pain or
yes, of
maybe
course,
trapezitis, they do present with a lot of dyskinesis, and
yes,
there are conflicting evidences regarding treating the same. Like
yes,
some literature, some evidences say that because it is there, you have to ignore it. And there are some evidences that say that you need to train this to, stop having this recurrent kind of a thing. So what are your views on this?
I think it depends of the population who is in front of you. If you have old people, I don't think that you have to treat specific dyskinesis. I'm coming from I was in Roma just this week for the International Congress of Physiotherapists, and there are a lot of communications about dyskinesis. And there is a lot of communication about dyskinesis for sports athletes, and that's normal. But in that kind of people, the dyskinesis is the consequence of the disease, consequence of the stiffness, and consequence of the weakness of the shoulder. So first of all, more mobility, and even if the scapula is not moving well, it don't matter. We cannot do anything, okay, for that. We can't do anything. And if the people have weakness, we try to give them more force with the other muscles. About the neck, I'm totally agree with you, and I do agree that patients have a lot of neck pain because of the movement of the shoulder. Right. Choose the arm, or they have neck shoulder. We can do, manual therapy, help them with the trapezius. Maybe we have to stretch a little bit the trapezius to help them. But I think actually with all the work I've done on the shoulder, that's the better way to release the trapezius, to have less pain of the trapezius, is to do shrugs with resistance. It's the best way. I did energy technique for 10 years or 15 years in my life, and now I do a lot of shrugs, and my patients they have less pain with that. So I think, I told you, there is no big guidelines. You do have to do with your experience, with your patient preferences too. If your patient likes to have stretch on the neck, you do stretch on the neck. That's not a problem. But the goal is not that. The goal is to have the arm that's going up and up.
Yeah, no, I asked you this question purposefully because of late we've been working with certain office goers, like those who are the desk workers, the computer workers, and we
Yeah.
have quite some work into this. And what we have seen is these kind of people, as such, they are absolutely normal, muscle power normal, everything normal. They just have long hours of sitting on computers, and what they end up is the trapezius and the secondary dyskinesis. And if we closely monitor them, their scapula is, I mean, it is bad to an extent that one patient that I'm of late recently seeing, he is presenting with this type 3 kind of dyskinesis, who is supposed to be a recreational player, and rest of the time he's the desk worker. So that is why I wanted to know what can we do to help out these patients. The younger lot, no shoulder stiffness, otherwise normal, just the neck pain.
That's another kind of patient. And in that kind of patient, I think there is a real place for not strengthening scapular muscle, because the muscle of the scapula are never weak. Just in the situation of neurological pathology. If you have a thoracic nerve, long thoracic nerve paralysis, you will have weakness of the muscles. But in all the other cases, scapular muscles are strong, very strong, but they do have motor control problem. So you can use very small weights or elastic band to do exercises with the scapula, like in ventral position, to do that kind of exercises with the Y exercise like this, on the arm on the up, and you are in ventral position. Or you can do like elastic band like this, and you can do even that kind of shoulder press with elastic band, and it will help your patient. What patient has to do is a lot of repetition. So if they do a lot of repetition, the resistance has to be few, not a lot. Okay, and a little resistance and a lot of repetition to get more motor control. We do know actually that workers in front of computers, they have musculoskeletal disorders because they have not enough activities, not enough global activities. Even if they want to run in the street, it's good for them. They don't stay 5 or 6 hours sitting in front of the computer. Every 1 hour, they have to get up and to do exercise with the arm. Every 1 or 2 hours, we have to learn them one exercise, just 1 or 2, to do with an elastic band like this or like this. Every 1 or 2 hours, they do just 10 or 20 repetition. It means that in the end of the day, they will do 100 repetition, and that will get less disorders for them on the shoulder and less dyskinesis.
Yeah, and of late, what I'm seeing is in the patients, there are a lot of active trigger points. Recently, I'm seeing one patient with a lot of trigger points on the pectorals, and that is mimicking bicipital tendinitis in that patient, and that is affecting his shoulder movement. Yeah. So any takes on that?
Yeah, you can find that. It's not specially for arthritis, but people who are very sedentary, you will find that kind of things. And trigger points, you see that kind of situation. And there is a lot of treatment, different treatment for that kind of situation. In France, there are people who are doing dry needling for the trigger points. I think it's a little bit dangerous on the pectoralis major or pectoralis minor. But another time, I think you can do muscle energy technique. It's easy to release the muscle with the stretching technique, and after you ask a contraction, and after you stretch another time with the breath of the patient, you breathe out, or another time you can do exercise. And if you do exercise on the trigger points, you can have good results too. So you are using the techniques that has evidences, and after with your preference, the preference of the PT and the preference of the patient. There are patients that don't want to have needle on them, and patients they like that. And there is evidence for the short-term results, good results with the needle. So you can use that. There are good evidence for short-term results for the manual therapy on the trigger point. You can do that. And there are results for short-term, medium-term, and long-term results with exercises. So you do what you want.
All right. Thank you so much. Now, there are a couple of questions that have come from our audience. I'll start asking them one by one.
Okay.
Yeah. So the first question was, somebody has written, why always one-sided shoulder spasm is there in the patients?
Why what?
Why
Why
always
is there
one
only one side?
muscle
Sorry.
spasm?
I'd like to know that, but I don't understand that. You know,
Yeah, even I
we
did
do
not.
know, we know
Doctor,
that we do know one thing is if you practicing a sport with one arm, like tennis player, like baseball player, you will have more disease in that arm, in that shoulder. Okay, but all the patients that are on computers or even with glenohumeral arthritis, it's one shoulder, sometimes not both. We do not know why it is one or the other one. Sometimes people say it's because they are sleeping on that shoulder, or sometimes other people say it's because they are more using that shoulder in their life. We do not have evidence about that. It's like capsulitis, it's a frozen shoulder. It comes in one shoulder, sometimes in the other one. We do not know why.
thank you so much. Somebody has asked that for a post-stroke patient, can glenohumeral arthritis occur?
We do have a big problem after stroke. What is the problem? The problem is that there is a subluxation of the shoulder because there are no more muscle, and we have an inferior subluxation of the shoulder, and it gives a lot of pain of the patient, and we do have frozen shoulder after that. There is a lot of frozen shoulder after stroke, but not arthritis. I don't know about that because the joint is not moving anymore, you know, so, but there is a lot of frozen shoulder.
And another question is, there is a 57-year-old female with supraspinatus tendinitis. She was advised surgery and refused surgery and refused any rehabilitation for her tendinitis. After 2 years, she saw there is slight improvement, but on and off pain. How soon would this lead to arthritis?
So what we do know is that if you have one tendon tear, like supraspinatus tear, 8 years after, 2 years after. So if she is 55 years old, at 63, she will have a bigger tear on her shoulder. And if she has bigger tear, she will have maybe more pain, and the surgeon won't be able to do the suture to repair the tear. 8 years later, it's not possible anymore, and she will have an arthroplasty. So it's very important to say to the patients, okay, you are 50 years old, you have a tear, it's better for you to have a reparation. If you are 68 years old, you have a tear, you don't have a lot of pain, you do not do a lot of sports, don't do the surgery. It depends of the age, it depends of the activities of the patient, it depends of the pain. If patients doesn't have pain, they don't do surgery. What we know actually is that if a patient do a surgery with and he's not agreed to do that, it's strange, huh? But sometimes the surgeon say you have to do the surgery. The patient really doesn't want, but he does that because the surgeon said it. We know that the results won't be good. So you don't have to do surgery to a patient who has not agreed to do that. You have to explain.
So earlier the
It's
better.
very important.
Earlier the better.
Yes. Earlier, if they are young, if they are less than 60 years old, earlier is better. If they are less than 65 years old, we can wait. If they have pain, surgery. They don't have pain, maybe it's okay.
There's one more question. We are working on exercises, but how to prevent trick movements during exercises?
What do you mean trick movement? Bad movement?
Yeah, so maybe some compensatory movement happening.
Okay. It depends. Like I said with my old patient just before, I said, this patient is doing a trick movement, but I don't care. If she is a sportswoman of 18 years old and she's doing that kind of trick movement, I will ask her to do another kind of movement. I will tell her, okay, contract your scapular muscles now. Contract your scapular muscles, and now you do the movement with the arm. Just before, I will ask her to do the movement with the scapula, and after to do the movement with the arm. But as I said, this patient, the old patient, it's not the same. She's doing the movement like she can do the movement, and I leave her. I let her like this.
What is the best way to educate about glenohumeral arthritis for prevention?
Oh, very good question. Very good question. The best way is not to have a diabetes. So it is to have a good nutrition. It is to do good activity. That is the best way. After that, if you have a trauma, maybe if you are young and you have an instability of the shoulder, the best way is to have the surgery early, the most early you can do it. The more dislocation you will have, the more probability you will have arthritis. So that's important. For young athletes, young sports, we see young people that are having dislocation. If they have 1, 2, 3, the better is to have surgery. Because if they do have 8, 10, they will have arthritis, and young arthritis.
And what about the common people who have been having this tendinitis or frozen shoulder? Do you think that if frozen shoulder, especially the diabetic frozen shoulder, if not treated well in time, can lead to shoulder arthritis in future?
No, there is no correlation between that two kind of disease. But if we don't treat a frozen shoulder, the frozen shoulder, you will have disability. We know that now. You will have disability and you will not recover completely if you don't treat a frozen shoulder.
Okay, fine. Any other questions from anybody? I guess no more questions. Thank you so much, Frederick Strohr, for being a part of this event. I, again, on behalf of our National President, Dr. Sanjeev Jha, our Treasurer, Dr. Ruchi Vashne, Vice President, Dr. Suresh Babu Reddy, and General Secretary, Dr. K. M. Annamalai, along with the entire Central Executive Committee, including me, once again, thank you so much for accepting our invitation and be there at such a short notice and make our World Physiotherapy Day great. Thank you so much once again, and happy World Physiotherapy Day.
Thank you, Nehal. Thank you for all physiotherapists Indian that were in the webinar or that will see the webinar after. Thank you for your association and for your work. I know all that is a lot of, it's a free work and it's a lot of time for colleagues. I know that, and happy Physiotherapy Day too.
Thank you so much.
And maybe see you in Europe or in India.
Anytime you can, we are ready to come to Europe, and very soon we'll be inviting you to India.
Okay, great.
Oh, there
Thank
are
you
few
very
more
much.
messages. Just wait. There are new messages that have come up. Let me see if there are any questions. Yes. There's one question. Can shoulder TB, that is tuberculosis, cause glenohumeral arthritis?
I don't know. Sorry, I don't know.
Yeah, because I guess in Europe, tuberculosis is not so much prevalent.
It's not so
Not
much
at all
frequent. Yes.
prevalent.
Yes, I don't know that question. Sorry for that.
Yeah. Anyways, thank you so much.
Thank you. Bye.
Connected.
Connected, so